Hi, everyone. This is Rafi. I'm here with Dr. Colin Champ. How's it going, Colin?
Very good. Thanks. Thanks for having me on.
My pleasure, man. Like I was telling you before we started recording, so I'm a big fan of yours because you had a podcast years ago, which was, correct me if I'm wrong, Roger and the Caveman. What was it exactly?
Relentless Roger and the Caveman Doctor.
That's it. Relentless Roger and the Caveman Doctor. That's nice. It rhymes.
That was all Roger's doing, the title. He gets full credit.
Gotcha. And it was an amazing podcast because we had your perspective as a doctor, and then you also brought the paleobiology angle, which was super important for me as a young guy trying to learn about nutrition and medicine. So that's how I became a fan of yours. And since I just started doing this podcast again, I thought it would be cool if we could just talk about all that stuff we have in common.
For sure. Amazing to hear. I'm glad people are listening to it.
Yeah. So why don't you tell everyone what you do in life, and then we can just go from there.
Sure. So I'm my day job. I'm an associate professor at Duke University. I work in the Department of Radiation Oncology. I specialize in breast cancer treatment and treatment of lymphoma and heme malignancies. And then my research, I have a pretty chunk of time dedicated to research, and that's broadly speaking diet and exercise and how it interacts with either cancer prevention or cancer treatment. But realistically, it's pushing diet and exercise in an extreme manner to hopefully metabolically influence both just overall health and specifically the treatment of cancer.
Cool. And is that what you've always wanted to do, or did you come to that in a circuitous path of sorts?
Little bit of both. I've always been really into manipulating diet and exercise. In college, I was an engineer and I wrote diets for people. I wrote exercise regimens for people. Did the same thing in med school. And then when I was looking for what field I wanted to do, I found the cancer field just fascinating, and I found radiation oncology very fascinating. It's very scientific, very heavy on machinery and tools, and basically like the dream of an engineer in terms of medicine. So when I went that direction, the nutrition and exercise aspect for what I thought kind of took a back seat, and then came right back around when we realized that, lo and behold, nutrition and exercise is important in every type of disease state present, and obviously in terms of maintaining health. So it's really taken a front seat in my life and in my research. And when I finished my training, which really all my research revolved around the diet and exercise, or nutrition and exercise. And right around the time I was making that podcast was when I was interviewing for jobs, and that was the only job I looked for. They had to be totally on board with my passion in that regard, and many places are. So it's really taken a front seat.
Oh, so that's good to hear. So it wasn't too hard to find centers who were friendly with that sort of approach?
It wasn't. It's really hit or miss. And weirdly, a lot of places that were friendly, at least on the surface, when I went and interviewed and gave a talk, my viewpoints are really questioning our antiquated models of like the food pyramid and obviously low fat, these kind of antiquated dietary approaches. I was pretty critical of them in my lectures, and I was lecturing to some people who were the exact opposite. So some people would get ticked off, but a lot of people, it was weird that even though they had opposing views, they kind of understood the overarching theme was to question these dietary messages, especially in the cancer world. I know in the diet world, it's a total minefield. Everyone's fighting all the time and having Twitter battles and whatnot. And yeah, you get a little bit of that in the cancer world, but really the cancer world just wants to get people to realize how important exercise is and nutrition is. Really, whatever whatever the message is. So I think they've been more open to it. And certainly 10 years ago, that was not the case. When I would write these articles on the importance of nutrition in the cancer clinic, I would get tomatoes thrown at me. In a short time period, that has changed. They're really looking for, well, at least on the surface, looking for ways to introduce nutrition, diet, and exercise into the cancer clinic.
And have you seen that manifest more as is it a nutritional shakes that have been introduced? Is it a plant-based diet? Is it keto? What have you seen?
So unfortunately, yeah, it always seems to migrate to some kind of supplement, right? Some kind of shakes, etc. A lot of us, I mean, my research is all real foods. The only, and we could talk about this later, the only non-real food is using a ketone, exogenous ketone ester, and that's for a whole different, I don't even consider that necessarily, food or nutrition. That's for a distinct pathway that may be dysregulated in cancer, but everything else is real food. So we have an intermittent fasting study where you simply choose 4 days a week to skip breakfast, which would be my preferred, or to skip dinner to just get 18 hours in. And then during the daytime when people are eating, we basically took one of the arms from the Diet Fit study, which was supposedly low carb, which we could argue about how much low carb it was, but it just focused on real food. It focused on, not eating meat, but if you eat meat, eat grass-fed meat. And so that's an arm of a randomized study, which we're now using in our protocol. So it's nice because we're teaching people about eating real food. We're not promoting any supplement use. We're promoting eating with your family or eating over the dinner table, not eating in the car. All those things they did in that study, which worked. There was an average weight loss of 8 pounds at a year. What we think is by teaching people or telling people to eat real food, by having them intermittently fast, and then an extension of that is another study, which is having them lift heavy weights. We think we can get them to not only lose weight, but improve their body composition. So lose fat mass and not necessarily muscle mass, hopefully build muscle mass.
And have you been able to see what kind of fat they're losing or gaining? Do you have that ability to look at the types of fat, or are you looking just at a general total fat mass measurement?
General fat mass measurement. We have a bod pod at the Duke Diet and Fitness Center. So that was kind of our first choice because it's non-invasive. It's not the easiest thing. You have to kind of go in Speedos and put a rubber cap on. So it's
I've done that.
Yeah, a little annoying for people. There's DEXA scans as well for a lot of the women in our weightlifting study are going on anti-estrogen therapy, and they're getting DEXA scans anyway. Again, not telling necessarily all these different components. And then there are some newer machines out there, these BIA machines, which claim they give you more specifics. I know they're less tested. So we're exploring potentially expanding to 4C type models, but right now it's the bod pod. Gotcha.
And before we were recording, you were also telling me about some of the studies you had in the works that got messed up by COVID, and they were really interesting. So why don't you tell us about them?
Sure. So one of my areas one of the areas that have really bothered me, and this can go certainly to the nutrition realm as well, but a lot of the exercise studies that we're doing or that have been done, initially we're testing safety in cancer patients, and obviously you always have to make sure it's safe first. Well, we know it's safe now, and we're taking breast cancer patients. So a lot of breast cancer patients, a lot of women with early stage breast cancer, they get lumpectomies, so a minimally invasive surgery. They get radiation therapy, oftentimes 1 to 4 total weeks. Not a lot of side effects in that regard. May be the only treatment they receive, or they receive anti-estrogen treatment, so a pill called Arimidex. So realistically, these women are very similar to the normal population. And so if I'm going to take my mom and put her on an exercise regimen, there's no reason why that exercise regimen should be any different than one recommended to a breast cancer survivor. So a lot of the studies have taken women with breast cancer. I'll just keep staying on women with breast cancer because that's where a lot of my work is, and had them do things like walk for 30 minutes a day for 3 to 5 times a week. And that's great. I'm not saying that's a bad thing to do, of course. But then we do things like test their muscle mass and their fat mass, or their weight loss, or their insulin levels, or hemoglobin A1C, or these several interleukins or tumor necrosis factor. We don't see any change. And then the study comes out and says exercise doesn't affect X, Y, or Z. And it's like, no, exercise may affect those. Walking 30 minutes, which walking is like breathing, right?
Mm-hmm.
Like we should all be walking miles and miles per day.
Mm-hmm.
And I'm not, for some people that may be exercise, and I get it, but for the general population, if we want to elicit these change, think about professional athletes or, weekend warriors, to get them to improve their muscle mass and reduce their fat mass or improve these inflammatory factors. It takes a lot, right? It takes lifting heavy weights. It takes hip hinge movements, dynamic movements, squatting, deadlifting, all these things. And so if you were a trainer and you were getting paid by your results, you wouldn't tell someone to walk 30 minutes a day for 5 times a week. You get fired, right? So what we need to do is bring people in. I mean, first off, every hospital should have a gym. It's asinine that doesn't necessarily happen. So we need a gym. We need trained personnel. We need these people to come into our facilities so we can have them doing these exercises that at home or unsupervised may be dangerous, though I think a lot of people would argue with that. But we need to do mobility screens on them, have them doing, if they can't squat because of mobility issues, then have them doing, goblet squats with a kettlebell or lunges, but they have to be doing these movements that by the end of the workout, you're struggling. It's really difficult, right? We need to apply shear stress to their bones. We need to apply shear stress to their muscles. So, sorry, that was my long-winded explanation of our study that was doing exactly that.
That's great.
Yeah, everyone got a FMS, and I know FMS, functional ability screens, have their issues, but there's not a lot of great screens out there. And so it was, number one, making sure the movement they were doing was safe and they were able to do that movement. That was the key. Not their METs on a treadmill or any of this aerobic type training, strictly strength training, closed, just multiple joint movements, in women generally at an age where they would never do that because it hasn't really been done in our breast cancer patients. That was a study that we were looking at. And so it's hard when you make a study that everything has to be hands-on, and then this virus goes around the world where nothing's allowed to be hands-on. Right. So that's kind of put a damper on that study. And I know some of the exercise studies out there have moved things to the home, but again, the whole point of this was to not have it in your home. And it was also kind of a CrossFit tribal mentality where you get everyone together, you get all these women who, successfully beat their breast cancer, and now you have them lifting heavy weights in a gym. So there was a community element of it as well. So that all just got destroyed from COVID, but it's going to come back. And I believe that if we can get these women to do these workouts, that this will become the standard of care, and it should be the standard of care. If I'm treating you with radiation for your 95% curable stage 1 breast cancer, I should not be okay with having you then go on and not exercise or do any of these other healthy behaviors.
Yeah, and it brings up something that I struggle with, and that I'm thinking about a lot for the work I'm doing for this clinic, where having to explain the difference between what's common and what's normal is like, it's such a big gap to bridge, because you have to be explained to people, like, you understand that you're asking them to do something that's totally out of the norm, but it's only with regards to what's done nowadays, not what's physiologically or mentally healthy for the average, like human, like at the most basic level. And And this is this big gap to bridge. So I love to hear that you say, we should have gyms in hospitals. I couldn't agree more. It's like it's very close to health and safety. Like you need to have people moving in areas where there are a lot of sick people. You can't have them too static.
Yeah.
It's that basic.
Yeah, change normal. You're spot on. I mean, normal right now is so far from normal, and we could. I mean, that's the other thing that just drives me up a wall is that, we tell people to exercise, and you're in Europe, so it's a bit different there. Here, we just have stretches of highways. Most people where they live, they don't even have the opportunity to walk, or they live in an area where it's not safe to walk, or you have to walk on the side of a highway with cars whizzing by you going 90 miles per hour. So there's not a welcoming environment to get people walking in the first place. So then walking in itself becomes a chore. So the normal thing is not walking. So getting people, I mean, the fact that some of our studies are getting people walking for 30 minutes a day for 4 days a week, I mean, that gives you insight into how far normal has fallen. It's unfortunate.
Yeah. It's a big problem, this behavior change thing, but that's not the only tool we have. You mentioned exogenous ketones. So maybe you want to say more about what you were doing with that, because there are so many different potential uses for it.
There are. So as you know, some of my earlier research was looking at the ketogenic diet, and we had a very small study that was a retrospective study, but a handful of people that underwent ketogenic diet while receiving chemotherapy, Temodar, and radiation therapy for brain tumors, for glioblastoma multiforme, which are very uniformly fatal brain tumors. Average survival is about 15 months plus or minus. So we had a bunch of people undergo that study, or undergo the ketogenic diet. We reported on it, and it was a bear. It was a total bear to get these individuals following it. A lot of them loved it because it gave them some freedoms. Some of them not so much. It was a struggle with their family to keep them on the diet. So it's a very difficult diet for most people to go on. And I've mentioned that on other podcasts, and people would argue with me about it. And it's different. And so it's very hard for maybe not you or me, but it's very hard for the average person to just switch to this diet. Add on layers of cancer diagnosis, chemotherapy, radiation therapy, stress, all these other things, and it's nearly impossible. So our study was a group of individuals who were going on it anyway. They were extremely motivated. We had a ketogenic diet chef on it. And so it was a very unique group. And really, we just looked at safety and whether it could offset the glucose rise that would happen from steroids, because most of these patients go on steroids, which it did, and it was safe. So really, having a big study where you put people on this diet, I think it will be feasible at some point. You have these Virta Health, or you have these companies now that can help people, and you with the app, some of these apps, et cetera, that can help people. We're just not there yet. So really beyond, so our last conversation was just general health of people. The question now is, can really severe dietary changes, or like a ketogenic diet, which really changes kind of the metabolic machinery within us, can that do things like treat cancer or sensitize tumor cells to radiation, or help with things like muscle loss? But getting people on the diet is exceedingly difficult. So one thing we can do is potentially test it. It's not exact, but we can test it through these exogenous ketone esters. And then if it shows some inkling of benefit, we can hopefully pare it back and do some dietary studies, at least show people that it's working. Because as you and I discussed before we started taping this, a lot of the things that we were talking about 10 years ago, we're still talking about, right? Like the diet, the ketogenic diet. I mean, how many poorly done mouse studies can we see, and how many review articles can be written about those poorly done mouse studies before you say, are we gonna test this thing or not? So I am not a proponent of pills and potions and supplements, et cetera. I think the diet in itself has many unique metabolic changes that occur that are not captured by simply giving someone ketone esters. But that being said, there may be a place for it. And so we're trying to figure out what that place is. And according to the internet, it's everything. They cure everything in the world, and we know that's not true.
Right.
So, and I'm a firm believer in the diet to some capacity. That the study that we ran, that we published on in those patients with GBMs, I was thoroughly convinced that it was going to make a huge difference. We just don't have the numbers to show that it does or doesn't. So, let's disprove it. Let's show that it doesn't work if it doesn't work. But if there's some signal that it does, then let's start, pulling on that thread. But at this point, we're just testing a whole bunch of different things, and we're not advancing. So the hope is we can isolate at least the effect of exogenous ketones on certain pathways, and then start to expand that to other areas.
Yeah, and it's this problem of testing the different components of what amounts to a metabolic therapy is a tricky one, because especially in the field of cancer, we're very wary about the sort of controls we use in studies. It's basically impossible, and correct me if I'm wrong, but it's basically impossible to get a control where there's a non-intervention. Essentially, you're always going to be getting some standard of care, which is most often chemotherapy or radiation, something like that, right?
Yeah, unless it's something like we have in our early stage breast cancer patients, we have studies where we just observe after surgery.
Right.
And that's the issue. The outcome is so good that these are studies that need to take place long, decades, and they have to have tons and tons of patients. So then what we do is we end up falling back on the really aggressive cancers, where everyone's getting an intervention, but we think then maybe we could see a signal, because if your survival is 15 months and you extend that by a month, you'll see that signal a lot better than like these early stage breast cancer patients. These are thousands and thousands of women on these studies. So you need some major finances to back them. And so, yeah, that's the issue. So you're not going to not do a treatment that works, and put a patient on that arm. Ethically, that'll never get by.
Right. So I was thinking about that recently, and I was looking at some reviews, looking at the overall. So it was the overall median relative survival, 5-year relative survival across many different cancers, and they were seeing that there was about 2 months median, which is really low. When you think about it, it's kind of disheartening in a way that that's only what's achieved. So I think, and I'd have to look into this further, but I think that implies that there are a significant number of standard of care treatments for certain cancers where we're not seeing a above zero sort of increase, or not reliably. And these are the cancers where I'm thinking to myself, hey, maybe this is the opportunity we have to test these things with true controls, where the ethical argument is basically open, where it wouldn't be if we were depriving someone of standard of care, which we wouldn't want to do, which was more effective. So do I have that right? Is there a problem with what I'm arguing here?
So you're saying that the gain in life is a median of 2 months?
Yeah, I've seen that in some reviews where from many different treatments you get overall median survival at 5 years of
5 years, I see.
2 months.
Yeah, I mean, for some cancers, it's certainly not the case, but for some, unfortunately, it is. I mean, I'll keep talking about GBMs because I've already mentioned them, but yeah, the last study that showed a benefit was Stoop, from Germany, and he gave people Temodar, and the survival went from just shy of 13 months to basically 15 months. So there's your 2-month gain. So yeah, it brings up an ethical, moral, ideologic question where we're stuck in this rut because we know the treatments. So that being said, in the 70s, they did dose escalation radiation studies where they show that for each increase, people live longer until you hit 60 gray, and that's like the standard now.
Right.
So we know that that increases your survival, not by much, as you pointed out. So the question is, are we willing to just pull back that and have people not do it? There are some long-term survivors. So of course, everyone is treating hopeful that they're going to be one of those long-term survivors. So it is a tricky, it's a tricky balance to say I'm not going to do any treatment or I'm going to do this new metabolic treatment. Our approach has always been, and that was our plan with the ketogenic diet, is to add it on, show it works if it does work, and then start pulling things off. I think that's going to be the more tolerable approach by the medical community. But it's just then a question of, if you start putting them on something that, and I agree with the shortcomings of standard of care in a lot of these cancer sites, but if you start putting them on a treatment that then has its issues, so they stop being able to get the standard of care, then ethical, IRBs are gonna block it. Yeah. So it is a difficult case, and the other problem is then you have people not doing standard of care that does work for this. So I've had some breast cancer patients not undergoing surgery or things like that we know works, that are extremely necessary, and going on a ketogenic diet, and the outcome's been unfortunately not great. The signal's not huge, right? If enough people are going on some of these treatments where if we saw a change, we would start to notice it. And I've seen a bunch of people go on the ketogenic diet, so I would have noticed it in my practice. So I think it's going to be multiple different types of treatments at the same time, and that's a whole nother. We can't, to your point, we can't test no treatment versus metformin and get rid of all the other treatment that works, right? And then no treatment versus something like 2-deoxyglucose. It's going to have to be multiple components, and it's been a bear to test these things, and getting people on a massive dietary change. Our intermittent fasting study is after all treatments done, and the primary objective is to look at adherence. So that's the other issue. If people aren't even on the treatment that they're supposed to be on, then you're throwing the baby out with the bathwater. So it's extremely difficult in multiple ways. So, but your point is certainly well taken.
Yeah, it's a tricky one because it's really like we were saying, dependent on the cancer, dependent on the standard of care in that disease, dependent on what the person is going to be able to adhere to. And even if the ketogenic diet works meaning that it addresses the fundamental issue with cancer, which in my view is a metabolic mitochondrial one, then you might not expect it to work even if it does address that, because maybe it's not enough. Maybe you need glutamine inhibition for the remaining, fermentative substrate. Maybe you need, I don't know, circadian realignments for some of that better oxidative phosphorylation. You could have so many different metabolic levers that you could pull, that you might expect a multi-pronged metabolic therapy to start making like you said, have signal, outpace the noise, basically, have something meaningful.
Yeah, that's the issue when we go from mouse to man. It's, we're looking at these single pathways, and then you start seeing what's actually changing, and there's 8 million things going. I mean, half of it, my head's just spinning. It was, every 10 years ago, can we starve a tumor? And that was kind of an easy pathway, right? Glucose in and out. And then you realize there's 800 other things going on. People, of course, talk about the glutamine pathways. And so, it's tough. Even, metformin, which has been touted as this wonder drug, the data hasn't been awesome with metformin either. And that's actually getting tested in an array of different studies. I mean, the medical community was really happy with using metformin. It's a cheap drug, doesn't cause a lot of side effects. Even we did a retrospective in all of our lung cancer patients that were on metformin, and we didn't see much of a benefit. Now, that was just a retrospective study, but So yeah, it just goes back to maybe putting someone on metformin alone isn't enough. Maybe putting someone on 2-deoxyglucose and blocking up hexokinase and not letting any glucose in barely at all, and then putting them on the ketogenic diet as an escape mechanism to fuel their cells.
Right.
Maybe it needs to be something intense like that, not simply, putting them on the ketogenic diet and then they're still going to have, blood glucose going in and out of these cells. It's probably going to have to be something along those lines, which it's just so difficult to study.
Yeah, that's what I'm thinking, because the way I tend to see cancer really is sort of as one of those diseases which teaches you so much about human health, because what's going wrong is going wrong at such a fundamental level. I think it's basically the cell sort of reverting back to an archaic mode where it shuts down many things that normal cells do, and then upregulates a few of these sort of like badass kamikaze genes where it can just ferment and suck resources very inefficiently, but really just take over and just induce heat, induce swelling, and have a lot of nutrients and toxic stuff swirling around, and it just sucks up everything around it. And I don't think you get that without changing something very, very fundamental at the level of the cell. So I think it's one of those diseases that I think we should see the surprising anecdotes we're seeing in brain tumors with people who have gone on a ketogenic diet. That makes sense to me, given the model of cancer that I have at the very least. But I can also understand why we're not going to see, crazy good remission rates, especially in pilot studies with small numbers, because we know there are other levers to pull on those things. So I'm not actually discouraged by it. I'm more like, okay, this still makes sense. Like we still need to test those things in the future.
Yeah. It means we need to test a lot more things. If there's a lot more variables, you obviously don't do less tests. We need to do more and more. And you're spot on with the fermentation. Herbert Crabtree wrote some of the initial studies comparing cancer cells to, fermenting yeast making wine. In his description, these are over a century old. I mean, his descriptions are spot on. The papers could be studied or could be published today. So well worth a read. But yeah, I agree with you 100%.
Yeah. And do you know, I mean, do you have a sense for how popular or if it's not popular, how popular the metabolic theory is of cancer? Is it permeating the consciousness in the oncology field, or what's happening there?
I think most people think it's a mix. Years back, people rejected it. Nowadays, I think the realization is there's a lot that we don't know. And so there's all these different theories, and that's exactly what they are, theories. We just don't know, we're getting closer. It's science at its best, right? We're just asking questions and proving things right or wrong. But I think most people agree it's a little bit of each. And if you gave a grand rounds at a university right now, I gave one to our heme group on kind of what we're talking about, on what diet would metabolically be beneficial for a patient with a high-grade lymphoma, and what exercise regimen would potentially be beneficial to a patient with a high-grade lymphoma. And I talked about heavy lifting, intense exercise, carbohydrate restriction, fasting, ketogenesis, and how they all kind of affect these overlap of pathways. And people loved it. I mean, that's what they want to hear. To your point about our minimal survival increases in some of these cancers, like we're looking for ways to improve them. We're not hard-headed as much anymore, though there's certainly some hard-headed people still in the field. But yeah, we're looking for ways to do this, and a lot of people are. And the other issue in a lot of my work is trying to bring this in is, on one hand, we're saying, can a ketogenic diet or metformin or one of these metabolic therapies work wonders in treating cancer, which that's, the goal, the massive goal here, which is easier said than done. And then on the same token, we're saying, can people just be a little bit healthier? Because look around, our whole population is spiraling downward in terms of their health, exercise. So if you're saying, well, maybe we have something that can do both, like very few people would be against that, right? So if we could show those kind of things, and I think part of it is going to be very low level exercise or diet studies, and just saying like, hey, look, we can make this change. So let's start adding things on. But to go from 0 to 60 and say, well, we need to do this, 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 and this, then we're going to kind of lose people in the weeds. But they're open to it.
Yeah, I'm really looking forward to the studies that are going to be done there, because there's a lot of low hanging fruit. So I hope the exercise study you were planning gets done sooner rather than later.
Yeah, I hope so too.
Yeah. I'd like to know a bit about what it's like to work in medicine during the last year and a half. So of course I've heard a lot of doctors talk about it, but I'd like to know how it was for you, and if it's changed your practice, if it's changed your views on medicine, your trust in science, anything sort of in that general area.
Yeah, it's been a strange time for research, for academia, et cetera. Especially for people like us, where our research challenges kind of some of the dogma out there, which is interesting, because I mean, that's what research should do. I mean, that is science, right? It's questioning what we think we know. There's just been a weird intermingling of policy, government policy, public policy, and then science. Like the two are, like, the food pyramid's not science, right? I know the food pyramid's dead at this point, but, well, kind of dead at this point. The food pyramid was policy, right? It was a bunch of people meeting in a room saying, here's what people should eat. Science questions that. So when they start calling that science, then that means anything questioning that is some weird fringe conspiracy. So it kind of became a weird period, because it's our job to question things. We're all wrong to some degree, right? It's just a question of how wrong are we? We're moving towards that right answer. That is science. So it's been a weird time. The word science lost some of its meaning because it was used so liberally to discuss all these different things. And the other thing it really did was, I mean, medicine is science and art. And so it's not black or white. It's just this gray area where we're constantly trying to figure out which side we're closer to. And it was kind of a year where that wasn't allowed, right? You weren't allowed to have nuanced conversations. It was all or none. Very few people were saying we don't know. And realistically, that was the answer to most of these questions, right? Like we don't know. When COVID first hit, so we were in Italy. We were in Italy when it hit in Italy. It was a weird, scary time. We had our 3-month-old with us, and we didn't know. If you look back at the Spanish flu, it was totally opposite, right? I think 2/3 of people dying were young, healthy people. So we were frightened. We were frightened for our daughter. And when it first happened, I'm working in the hospital, right? And you're hearing all this stuff about what's going on in northern Italy, and it's all the people working in the hospital. So we were scared. One of my colleagues, we were going to move in together, and then his wife and kids were going to move in with my wife and daughter to just create some distance. So we were so scared. And the answer at that point for everything was really, we don't know, right? We didn't know. So once we found out that it wasn't harming young people or children, etc., we were relieved. And it was a weird thing in that as we got more information, I feel like we knew less and less, but no one really admitted how little we knew. So just a strange time. And also just so uber, I mean, it was at a terrible time in the US, obviously, just uber political. So everyone just kind of put their head down and didn't say much. And unfortunately, I'm not a virologist. I'm not an epidemiologist. there's a lot of extremely smart people out there that I wanted to hear what they were saying, and their head was buried in the sand. So it was a weird, a weird time. I'm interested to see what people down the road, how they look back on this and what they say. People that know certainly better than you or I how these things work.
Yeah, I hope we one day get to see a full investigation into the origins, because that's really important to know about how it came about if you're going to try to devise vaccines or anticipate how it might mutate, stuff like that.
Yeah.
And the fact that that's been politicized is a real pity, because it just hurts everyone not to know, like, for sure.
100%. Any politics and science is bad. I don't care what viewpoints people have. Yeah. It's like the two need to be so separated. Yeah, it's weird. It was also interesting because when they showed that people with medical conditions were at higher risk, we obviously need to protect those people, protect our elderly, but B, it was kind of a green light to say, hey, this is yet another reason to start putting more dedication, whether that's time, effort, or money, into getting people healthier. I mean, it's the same thing over and over again, right? And breast cancer, people with other medical issues, people with more adipose tissue and less muscle do worse. In COVID, the same people do worse. These are the people we need to help, right? We have just poking at me, my friend sent me, there's a link. We have a donut maker here called Krispy Kreme. Mm-hmm. And if you showed proof of a vaccine, you got a free donut every day.
Right.
I'm like, this is not the message we want to promote to people. I get it. Like they want to promote vaccination for at-risk people, but we probably don't want to promote donuts for at-risk people. We want to give them free gym membership to the gyms that should be at hospitals.
Well, I don't know, man. If it were me, I would be offering cigarettes for people to come get, a breast exam for cancer. But that's just me. That's just how I do public health. So I don't know why you're criticizing the donut people. I mean,
but you can't say stuff like that when you're a physician who's supposed to be making people healthier, and then that stuff's going on. It's a weird. We published a paper a couple years back looking at vending machines in hospitals, and vending machines in hospitals are owned by Pepsi and Coca-Cola, not by the hospitals, and they mandate what the hospitals have to put in their vending machines.
Oh my God.
It's total madness. And then when a pandemic happens that affects the people with the least amount of health, and you see these kind of things, you can't be an educated person that thinks through things and not have your brain kind of explode.
Yeah, there's a lot of self-inflicted harm in this whole story, and it's nearly, I often feel as if I'm talking about this other thing, because I see it as two concurrent pandemics where we had, this diabetes or metabolic syndrome, like giant wave that's been building up for ages, and then we've had this novel coronavirus, so to speak, and then we have this perfect confluence where we're essentially confronted with the massive errors that we've been accumulating, and the way out of it really isn't about learning lessons. I mean, there's a lot of amazing technology that's being developed, and that's great, but it's also thoroughly missing the point about being about how you can avoid. It'd be great if we developed mRNA technology and we had trials with sufficiently large people over sufficiently long periods of times with better outcomes like hospitalizations and deaths rather than maybe just infection. That would be ideal. Of course, we can't have that now, but that's the way we would like to go about it. But when we have so many sick people, then everything changes. The considerations just go out the window.
Yeah, and we see it, as an oncologist, we know this in my field, right? If someone gets breast cancer and they have no other medical issues, they're healthy, it's a lot easier to treat than someone who gets breast cancer that has an array of health issues. Like it's just common sense. So at some point, smart people have to say, well, what do we do to decrease all those other things that are actually getting in the way of curing breast cancer? Right. And what we're seeing in our society is, I can't do anything about that. I'm going to cure your breast cancer. We're going to do surgery. We're going to do radiation, or I'm going to cure your ductal carcinoma in situ with less than a % chance that this will ever shorten your life or kill you. And then I'm going to ignore the fact that you have all these other things going on that are going to kill you. And I get that, we don't want to judge people. We don't want to do all those things, but at the same time, we have to say, what are we doing wrong? And how do we fix this? And to your point, it's not some, gene therapy, or it's just be healthier. And we're not helping people. I don't have any sweets in my house, because if I did, I would eat them. Yeah. So why are we putting sweets in front of patients' faces in the hospital, where they're there likely for diabetes or diabetes related illnesses, where it's messing with people. It's not treating people like people, right? I don't know. And so as long as that happens, we're going to keep having these issues, and it doesn't need to be, replace COVID with 8 million other things, right? It doesn't have to be COVID. It's any medical illness that could come about. If you have all these co-issues, we know what the end result is, and it's not good.
Yeah, we don't learn our history very well. We point to Semmelweis as this example of, oh, look at how this really forward-thinking guy got it right, and we didn't listen to him. And we're doing this on like 10 other counts nowadays. Vending machines, the stuff where you don't even need to be a doctor. You just need to be a 12-year-old who's heard some stuff, at the dinner table or something. That's pretty much what you need to know to be able to get that through. But yeah, we're really lagging behind in that regard. I had to sort of deal with hospitals during COVID, because my dad got he hit his head in December 2019, and then a couple months later he developed a bilateral subdural hematoma. And it started to really, mess with his cognition, his memory, and his balance, and a lot of things. So so he's fine now. He's doing great, but he had to go to the hospital, and multiple times, and it was just a mess dealing with that, throughout COVID. And it was jarring, because I got to actually speak with some of the staff about what they were feeding him, what they would do. And the people are really there to help, but they have just been given the wrong message and the wrong tools to do their job, and all of the incentives are misaligned. So it's very difficult, I'm sure, for the doctor and for the patient, because you see how things are just not working smoothly. Basically, there's no coordination between the different services. There's no health philosophy. Like, no one understands what a basic view of health is. There's no, I don't know. It seems very discoordinated and uncoordinated to me.
Yeah, hospital food's the easiest. Like, you can't. Everyone knows hospital food's terrible. Everyone in the hospital says it. All the doctors know it. All the patients know it. And when my wife had our baby, I brought her all her food. And some of the days I was working, so I'm like running over. And the fact that everyone knows it, but no one cares, is like, therein lies the issue. Or we can't do anything about it. Or, at a prior university where I worked, I met with the head of food services, and I brought up all these issues, and I said, here's what we can do. And she said, I would stop right there, because everyone else who said what you're saying now no longer has a job. Yeah.
Okay.
So yeah, when you're, we're handcuffed, we're trying to help people, but then at the same time, we're told we're not allowed. And I think COVID did a really good job of illustrating that, where no, don't talk about all those things that are going on. We're gonna in getting people healthier, or getting people the vaccine, or getting people to, whatever scientifically makes sense. They don't have to be mutually exclusive. Mm-hmm. Right? We can tell a 70-year-old with diabetes that the vaccine will be good for them, because if they don't get this disease that could kill them that they're at high risk for. But we could also say, oh, while you're at it, this may help you too. It doesn't have to be one or the other, but
Yeah. Yeah, what it's, of course, it's always easy with hindsight, because and I've spent a lot of time reading about epidemiology and statistics and viruses in the past year, and I really can't help but think to myself, what if we told people, okay, there's a very highly transmissible virus going around that many of us are not going to have a lot of prior herd immunity to, although we might have some because we've already had a SARS coronavirus in 2003. And we know there's cross immunity, but basically probably don't stay inside. After the first couple of weeks, we understood inside was bad. We should have paid people. If we were going to furlough people, how about we furlough them to go outside and pay for build like outside gym areas, like quick, because we need to get people outside. Imagine if we'd done that, if we spent money that way. Like you could have done really ambitious things, but instead we doubled down on what we were doing poorly, and we tried to dug our way out of it that way.
And it's, I mean, to extend that even further, like we know that at some point there will probably be some other similar situation. So wouldn't we prepare for that by doing all the things you said, right? A healthy, resilient population, right? A population that when something like this comes, we don't have to worry as much, because the people with the immune systems that could fight it are the majority of the population. Like, that seems like a prudent strategy. And I'm not saying to get rid of all the other strategies we're doing. You can work on those too. But yeah, and that's a whole nother, our communities have been really, really destroyed, in it's suburbia. You want to get people outside, but a lot of places here, there's nowhere for people to even get outside. So there's so many things we need to untangle here. But I agree. I think getting people outside is the number one thing.
Yeah, you get so many, it's such a parsimonious intervention where you get vitamin D, you get better air quality, you get it's easier to distance in a sense, and you basically get zero transmission at daytime outside. It's close to nil as far as we know. So we have all these things we didn't exploit, and it's so difficult. It's hard to say, oh, I have this very simple solution to this incredibly world-changing complex problem. That's very, very hard to to get through in public health.
The simple solutions are the best. Just shut down the internet and cable TV for about 2 weeks.
Yeah. Soon, no more bipolar, no more schizophrenia. Mental health getting better. Yeah. Tell me a bit about your diet, and before we close up, what are you eating nowadays? How has it evolved since the podcast, I guess, in 2013, 2015?
So it's still pretty similar. Lots of meat, lots of vegetables, lots of healthy sources of fats. Still eat decent amount of raw cheese, grass-fed cows. Right now, I've been working out a lot for hypertrophy. I think partially because of my study and working with really, really good exercise physiologists for the workouts that we were having people do, kind of motivated me to work more on hypertrophy. So I've been eating typical, high fat, low carb throughout the day. But after my workouts, I pound quite a bit of carbs. So whether that's white rice or sweet potatoes or berries. What's interesting, I have a ketone breathalyzer. It's Biosense is the company, and I'm one of their scientific advisors. So that's my conflict.
Oh, cool.
So, but it's a cool device, and so I've been tracking. It's interesting. I've been eating quite a heavy amount of carbs after my workouts, and they do not bump me out of ketosis. Like, I'm not even purposefully in ketosis.
Right.
But you really just oxidize and burn up everything you eat after a workout. So it's pretty pretty amazing. So if I take you through a day, basically coffee with heavy cream every morning, breakfast usually, especially for a workout day, is like 6 eggs, onions, spinach, a little bit of cheese, and then lately, like I'll put kimchi on it or something like that, something fermented. For lunch, again, depends on my breakfast, but something similar. So always a plate of some kind of vegetable, some kind of colorful vegetables, and then some meat source, whether it's shrimp or something else. And then for dinner, so then my workouts, depending on my work day, my workout can be any point throughout the day. Again, some heavy carb loading after. And then dinner's a similar meal, just either up or down in terms of amount based on what I had throughout the day. And then a couple glasses of polyphenol-rich red wine.
Nice. What is it? Chianti?
Some Chiantis. My wife runs a company that finds polyphenol-rich wines.
Oh, cool.
So yeah, so I have to try them all. So it's the
heavy comes the burden.
Yeah, it's tough. It's really tough. So we've Sagrantinos recently have been. I don't know if you had any, but they are like rip your tongue off tannins. That's been our favorite lately.
Interesting. I see. This is the thing. My brother's a really good wine connoisseur, but I fail to really appreciate it fully. Like I can tell you if it's terrible or if it's good, but I can't fully, like, I can tell you, okay, it has more or less tannins, it's floral, but that's about it. I think my ability has it stopped at like a 16-year-old's palate, basically. It hasn't ever evolved to a 30, 40, 50-year-old person, respectable palate. So I drink very little, but but I enjoy it sometimes.
When you do, I mean, you're in France, go get wine from Cahors.
From what, sorry?
They're French wines from Cahors. Some of the best, highest polyphenol wines, and you'll see the difference.
Okay, I'll have to try that. If I can come up with something cool about wine, I'm gonna impress my brother. So maybe I'll try to do that.
There you go.
He'll respect me more. He has a lot of
the Russian Tsars used to drink it. They said it helped with their dyspepsia. So there you go.
Oh, that's interesting, because I think, if I'm not mistaken, there are some glucose inhibitors, some polyphenol glucose inhibitors that slow the absorption, I think, of the.
Interesting.
I think, if I'm not mistaken, that may be why it helps with dyspepsia, which kind of would make sense if you can reduce the absorption of carbs, I guess.
I will ask my wife. She knows. She's the wine science whiz.
Yeah, please do. See if I'm not full of shit. But I think that's what I'd read. Yeah.
She told me the other day I had some wine after exercise, which she brought up to me right away, that I was reducing mTOR. Some of the polyphenols are mTOR inhibitors.
Right.
So I was reducing my hypertrophy.
That's funny. After a few years back, when I was going to this CrossFit gym, I had a friend who would make his own rum with very different fruit and all mixed at home. And so he brought some, and we just finished a CrossFit workout. So you're sweating, in a sweat angel on the floor, catching your breath. And 5 minutes later, I'm tasting this delicious, like, kiwi, banana, peach rum. And it's just, it's served in a very small portion. And oh my God, did it go straight to my head. It's the smallest volume of alcohol I've ever drank, where I'm like, damn, I'm already sloshed. It's crazy right after the workout.
Yeah. Post-workout alcohol, not the best.
Yeah, that's true. But no, but it was worth it. It was good rum. And again, I don't have a good palate for alcohol, but that rum was worth it. Homemade stuff. Same with homemade foie gras, all that stuff. It's really something. Yeah, I haven't made that yet, but a friend did, and it's crazy good. It's so cheap. I think if people knew how cheaply you could make like high quality 3-star, restaurant food, that people would do it more. Good foie
Yeah.
gras, homemade.
My
It's
my
killer.
wife makes duck confit usually once a
Oh,
week or every other week.
that's
And,
amazing. I love duck confit.
yeah, it's unreal, and it's you would pay top dollar at a restaurant for something
Yeah.
that costs us not very much.
This is why I don't like. My girlfriend's like, oh, we don't go out enough. I'm like, yeah, but we eat so well at home. Like,
If you cook, you can usually outcook most restaurants
Yeah, totally agree.
for a fraction of the price.
Yeah. Yeah, and most of that is in the ingredients. You don't have to be a crazy good chef. Just if you can cook, if you can not overcook your steak, you're good, basically.
Exactly.
Yeah.
Yeah.
Oh man, thank you for taking the time to come on the podcast and talk to me. It was a lot of fun.
Yeah, thanks for having me on. Good
I'm
chatting
glad
with
we
you for
got
sure.
to do this and talk about how it is in the field of cancer, because it's been a big topic with me and some coworkers of mine recently, trying to help out a family member who's had breast cancer. So we were going over a lot of the literature, and I was reading a lot of your studies actually,
Oh, awesome.
in that regard. So thank you for the help that provided. So
Absolutely.
yeah, please keep doing what you're doing. We need those trials to get done, and yeah, just thanks for doing what you're doing. It's a great help to a lot of people.
I appreciate that. You as well.
Yeah, thanks. All right. Well, everyone, please check out Colin's old podcast if you want to go back nearly 10 years. But I'll link to some of your presentations like IHMC, I think you did, all of that.
Yeah,
That was
there's a
great.
couple there. In my new
Yeah.
book, Leonardo's Legacy, discusses a lot of the things we discussed today about food and metabolism and cancer, and
Oh,
probably
nice.
asks more questions than it answers, but that's really where we
Mhm.
are at this point.
Do you have the book with you?
I do not.
I was going to
I
ask
should
you to
have.
show it. Yeah.
I'm terrible. My wife always yells at me. I'm terrible at self promotion.
No, that says good things about you. Trust me. But no, yeah.
It's
Is there an Amazon link already?
Yeah, it's
Something
at
like that?
Amazon. It's all
Okay,
those places. Yeah.
perfect. Perfect. People can check it out then. I actually didn't know you'd written that book. I missed that. I'll have to check it out.
Yeah, it came out right before COVID. I actually had I had a couple talks to give on it in Italy, actually.
Okay.
And they all got canceled. So
Shit.
not that. So there was worse things from COVID, so I'm not gonna complain. But yeah, it's out.
All right, cool. Well, best of luck. I hope it makes a killing, and people need to hear that message. So go buy the book, everyone.
Yeah, that's I'm not making any money on it. I don't care. I just want the message to get out there. It's a passion project.
Awesome. All right, thanks.
Thank you.